Hi, good evening. My name is Justin Continiclo. I am from the Ridgewood Public Library. Tonight we have Dr. Kevin Giangrasso, a licensed psychologist who specializes in evidence-based treatment of individuals and families across the developmental lifespan. He's extensively trained the psychological treatment of depression, obsessive compulsive disorder, post-traumatic stress disorder, sleep, disruptive behavior disorders, and ADHD, and anxiety-related difficulties such as panic disorder, specific phobias, generalized anxiety, social anxiety, and stress. And tonight, he is running our webinar program for teens, actually for families, management of teens, stress, depression during the time that is now. This session is being recorded, and if you'd like to save some questions at the end, we will totally do that. We will stop the recording. But I'll let you go, Kevin. Thank you for everybody that's joining us tonight.
Yeah, thanks for being here. And thanks for that introduction. We are going to, I'm going to pull up my PowerPoint in a second. But before I do so, and I'll start to present that, I want to try to make this talk and these talks in general, I want them to address the questions of the participants. So if you could take a minute and just think about any specific questions that you might have that you would like this presentation to answer, please take a minute and just write those down. If you feel comfortable doing so, you can, I think you can put them in the chat box or the questions and answer box. And that way we can see all of them. Okay. Justin, is there a chat box that I can see or no?
Yes. Should be at the very bottom. Yeah, I have it open. I don't think anything's come through just yet.
Okay. All right. So just feel free to put those in at any time. And in the meantime, what I'll do is I'll open my PowerPoint and I'll just start presenting. Thank you. All right. Go. Okay. Thank you for that question that someone just put in there. Oh, screen says chat disabled on my end.
Let me try to play around with it. Let me see 1 second.
Okay. All right. Okay. So tonight we're going to talk about these topics. We're going to talk about some stress. We're going to talk about depression. We're going to talk about low mood, which I would say is part of the umbrella of depression, or what we commonly talk about as depression. And we're also going to talk about risk. By risk, I mean any dangerous behaviors that our adolescents are doing. We're talking about behaviors that are done that are risky, that are done on purpose. And we're talking about behaviors that are done not on purpose or accidental, but they are behaviors that are somewhat risky in that if the child is doing it, they put themselves at greater risk of hurting or killing themselves. So primarily, we're going to be talking about middle and high school aged students. We're going to be talking about the definition of what depression is. I think depression is one of those words that we use a lot, but we often aren't specific about what we mean when we do so. And I want to talk a little bit about how depression or feeling low is different, or how we observe it differently with adolescents. I want to talk about risk and suicide. I also want to give some idea of, as adults, what kinds of things, if we see those things, we should be worried. So what are the red flags, or what are the yellow flags? And I want to talk a little bit about the treatment and support for low mood and depression. The good news is there are some really great treatments out there that really work. Okay. So I'm gonna leave. Take a minute and just read this slide as I just talk about what depression is and what it isn't. So major depression is defined by a book called the DSM-5, which basically creates the definition of the constellation of symptoms that, if they are found together in a person, that person is what we call meets criteria for depression. Depression is not feeling down. Depression is feeling down most of the day, more days than not, over the course of 2 weeks. So some of this is about the intensity of the feeling, and some of it is also about the co-occurring symptoms that go along with feeling down. Depressive disorders, or depression, typically falls into 2 different categories. One is the depressive disorders, which, if you think, these are disorders that bring our mood down. And then the bipolar disorders, of which there are a few, which are typified by an up and down mood. So there are some times when someone feels elated or really excited in an expansive mood, which is called mania, and other times they feel really, really down. This slide defines what I was just saying, basically. So depression is a symptom. It's feeling sad or miserable. Depression can also be understood as a syndrome or a constellation of a number of symptoms together. Depression, the disorder, is a number of symptoms together in a very specific way. Children and adolescents, in the past, it was understood that children and adolescents do not experience depression. We now know that this assumption was wrong, and school age, even elementary school kids, certainly middle and high school kids, do experience depression. It is oftentimes overlooked because of, and the theory is of why it's overlooked is because, for a couple different reasons. Number one, there is a lot going on in the life of a middle school kid or a high school kid. There's other behaviors that they are doing, maybe oppositional behaviors. Maybe they're very socially focused at that time. And the depression that they're experiencing doesn't really show itself in the way that we would expect. For example, irritable mood is a very common symptom of depression for adolescents of these ages. It's a lot more common for a depressed 13-year-old, for example, to be irritable or to be upset or annoyed than it is for a 13-year-old with depression to just be really, really sad and isolating themselves. As we talk about these symptoms more and more, we'll also realize that there's a lot of overlap. So if we think about teenagers, one of the main things we often say about them is that their mood is up and down. They're sort of all over the place in that way. Another thing that we say about them is that they don't really like to do what the adults around them are telling them to do. They're oppositional, maybe even. Maybe they are even easily annoyed. So all of these things are also symptoms or experiences that could map onto a depression diagnosis. So I guess what I'm saying is that for this age group, it's important to be specific and really observe what you're seeing and to try to determine, is my child really feeling low or really feeling depressed? And this is sort of how it's coming out. Or is it typical range adolescent type of behavior? Between 2 and 8% of children aged 14 to 18 experience major depressive disorder, which is a diagnosable depression. So that's a lot of kids in this age group. And this particular stat starts at age 4. So, and we often think of kids that young not being depressed, but it is possible kids that young do become depressed. As kids get into adolescence, this is when depression becomes more prevalent. In those early teen, 13, 14, 15 years old, these are the ages where we start to see a significant increase in depression among these age groups. Some of that is explained by rapid hormonal changes that happen around those times. I also imagine, the increase in socializing at that time can create situations that might make depression more likely to present itself. Comorbidity is just a word for those disorders that often go along with depression. Things like anxiety disorders often go along, depression and anxiety sometimes co-occur or often co-occur, and others. I'm just going to stop for one minute and just ask anybody if they had anything to share in the chat box. I'll give one more chance. Okay. Depression in the adolescent years, as I was just saying, common onset is age 13 to 15. On average, an episode of depression will last about 8 months. In this age group, although obviously that's an average. So depression can last as short as 2 weeks, right? Someone can meet criteria for depression in that initial 2-week period. And then sometimes it goes away, right? And sometimes it does go away on its own. Sometimes it might last longer than 8 months. I think it's important also to know that individuals without a history of depression do develop depression sometimes. And vice versa, someone may have a significant family history for depression, or they may have had past depression experiences themselves. Doesn't necessarily mean they're going to develop depression, but it does make it more likely.
Hi, Kevin. I'm sorry to interrupt. There is actually a question that came through on the chat. It asked, can you address loneliness, please? Is it kickoff to bigger mental health issues and screen usage? Okay.
Yes, we can address those things. Thank you for your question. So how would I address it? So I guess what I would say for the question about, is loneliness a kickoff to larger mental health issues? So it's my opinion that loneliness or avoidance in other words, avoiding the issue or avoiding the difficult feelings that are being experienced typically will make a mental health difficulty worse. So, in other words, and we'll get a little bit more into this, and I'll refer to it when we get to treatment of depression. But if we're feeling really low and we're also feeling lonely, oftentimes that will create like a dynamic, or sometimes we'll call it a self-fulfilling prophecy, when if I'm having very negative thoughts about myself and at the same time I'm lonely, it creates a situation in which I'm more likely to look out at the world and see the world as confirming the belief that there's something wrong with me. In other words, if I think I'm lonely because nobody likes me, because there's something wrong with me, and then I go to school and I look around and I see the reality that I don't have a close friend right now, that might make me feel even worse and create a dynamic where I might, in my thoughts and feelings, go downhill. Loneliness per se is not a cause of mental health difficulties, but I would call it more of a symptom or an outcome of mental health difficulties. Screen usage, on the other hand, is it's tough. It's tough because so many screens are used, and often, specifically with depression and loneliness, kids sometimes get stuck in a negative cycle of being convinced that particularly the multiplayer games and sort of the social aspect of screen usage is almost used as a confirmation that, see, I do have friends. But the reality is that level of connection, it sometimes will make people feel even more lonely. Because if the person you're playing a game with is in another country or is in another situation, or you know that you'll never actually meet them in person, it's not a full relationship, right? And it's not, it can create a negative or unhealthy pattern. And then there's also the pure amount of time on screens, right? The reality that if you are spending 5-6 hours on a screen, that's 5-6 hours that you're not spending doing active things that are going to help you with your mood. So please send a follow-up to the chat if that does not address the question, or if you have a further follow-up after that. Let's see, where are we going to go? Okay, so in terms of onset, course, and outcome of depression, most children eventually recover from that initial episode. Again, which is a 2-week period. And then many times there's what's called recurrent depression, where depression comes and then it goes and then it comes back. And here's just some stats about the likelihood of depression coming back if it's been there already. Here are the 5 main recommended treatments for depression for kids. And so if you are taking notes or writing something down, these are 5 terms that are really good to write down, especially if you're thinking about treatment or finding treatment for your child. The first is behavior therapy. Then we have cognitive therapy, cognitive behavioral therapy, interpersonal therapy, and medication. The first 3 are very interrelated. So cognitive behavioral therapy basically is a mix of behavior therapy and cognitive therapy. Interpersonal therapy, it should be IPT, is a little bit of different, and medication I think we're familiar with. And I'm going to get a little bit more into these treatments in a little bit. Let's see. Okay. I want to talk a little bit about cognitive and behavioral therapy. So part of how we understand how to help kids with depression or kids with low mood is based on how we understand depression to have developed. The CBT theory of depression is the idea that we have thoughts that are depressive, right? We're thinking negative things about ourselves, the world, or the future, and that we're doing behaviors that are confirming those negative thoughts. So maybe we're doing more avoidance than we were before. Maybe we're on screens 5 hours a day now, and we used to only be on screens an hour a day. We're doing new behaviors that are likely to make us feel worse. Maybe in the short term we feel better, but in the long term we feel worse. And cognitive behavioral treatment for depression aims to work with that person to find the areas, the behaviors that they've been doing that are maintaining or continuing the depression, and find the thoughts that the person has been telling themselves that are maintaining or continuing the depression. And the idea of CBT is that we can change our thoughts directly. In other words, we can practice the skill of not believing everything that we think, and we can practice the skill of actively changing what we're thinking. We can also, the assumption is that we can also change our behaviors directly. We can make choices to, instead of sleeping in, we can force ourselves to get up and get out and exercise or do something healthy. We can, and a number of other behaviors. And the theory is that we can change our feelings, but we have to do so indirectly. We can't force ourselves to feel different. And if we try to start forcing ourselves to feel different directly, it's probably going to be disappointing because we end up not feeling any better, even though we're working really hard, and that may confirm the depression. So we want to work primarily with our thoughts and with our behaviors to change the way we feel. This is the graph of what I've been talking about. So cognitive behavioral therapy in a nutshell is the understanding that basically our life within the world and within our relationship is made up of behaviors at the top, emotions, and cognitions or thoughts. And each of these things are bidirectionally related to one another. So for example, if I have a low mood thought of, I stink, nobody likes me, I am less likely to go out and try to meet someone new. And that's the behavior. If I don't go out and meet someone new, the emotion that might go with that is I might feel lonely or I might feel sad. And then that feeds back into the future thoughts I will have. And on and on and on. Sometimes it starts with the behavioral choice, sometimes it starts with the feeling, and sometimes it starts with the thought. But the idea is that each of these three things, each can influence the other one. And the treatment comes from changing two out of these three, changing our behaviors and changing our thoughts. The emotions or the feelings that we feel, we just want to work on accepting and validating that it's okay to feel any way we feel. The idea of thoughts or thought errors is a very cognitive behavioral therapy idea. So there's an idea that we tell ourselves things called automatic thoughts all day. Sometimes these thoughts are wrong. And sometimes we listen to the thoughts that are wrong. A very common type of depressive thought might be something like, nobody likes me. Well, for the majority of people in the world, that probably is not 100% true. There probably is one person, two people, a few people in the world who do really like you. But when we're feeling low and we're feeling depressed, we convince ourselves that it's all or nothing, that it's nobody in the world likes me now and nobody ever will. And then that feeds the depression. Any questions at this point? Thanks for the feedback on that chat, by the way. All right. I want to talk a little bit about suicide and risk. Before I do, I'm using the word suicide intentionally, and that is because I want to make the point that we often don't make, and that's the point that suicide risk does not go up by talking about it, especially when it's talked about in a professional setting. There's often a we want to talk about it candidly, I guess is what I'm saying, because as we're going to see in the next couple slides, it is something that happens. It's something that we want to be aware of. It's not extremely common, but it does happen, and we do want to be aware of what I would call the yellow flags and the red flags. So the yellow flags being something that kind of like we want to keep monitoring, some behavior that we notice or some just feeling that we get that we want to notice that worries us. And a red flag is more of, this is something that needs action right away. A behavior, a comment, something that we observe that we really need to flag right away and get some support for. The definition of suicide is death caused by self-directed injurious behavior with any intent to die as a result of the behavior. So there has to be the intention of killing oneself, and it's self-directed. As an aside, the preferred terms, or the terms that are probably best at this point to use, are death by suicide or died by suicide. You'll see some other terms in there that are not as accepted as those, but still used. Other piece, other point I want to make is this third bullet point: suicidal ideation. That's about thinking about suicide or thinking about death, thinking about one's own death. And the intensity of those thoughts couldn't vary more, right? So the thought of thinking about death or thinking about suicide in relation to yourself is actually not an uncommon occurrence. It happens to people all the time. What most people don't have is the intent associated with that. So suicidal ideation, or thoughts of suicide that are fleeting, without intent, that are just kind of float in and out of our brains, are much less dangerous, or there's much less risk there than someone who has an intention of hurting or killing themselves and has a plan to do so. I see a second question that's a really good question, and it's related to cutting. So I'm just going to read it. So, thoughts on cutting and why teens are using it as a means to relieve stress, suggestions to help support a teen that's doing this. That's a really great question. Cutting is what I would call one type of self-injurious behavior. So cutting typically is done without the intent of killing oneself, and often it is described as a stress reliever. My thoughts on this are the following. So first of all, as people do all kinds of behaviors to relieve stress, and kids do all kinds of behaviors to relieve stress. Cutting is not different than those behaviors, other than it's much more dangerous, because there's a sharp object involved, and there's breaking of skin involved. So the sense of I have intolerable feelings that I want to relieve by cutting myself is if when we look at it as a behavior, it makes sense, and it's maintained because that person gets some level of relief from it. There's some release or some feeling that they get that's it's like a reward. And so the treatment for cutting, or the best way of support, is to try to find a way to replace that relief that the individual receives, to work with them to try to find a way to find that relief without doing the dangerous behavior. So in other words, to find that same type of relief by doing something else that's less dangerous. And that's what's called it's a harm reduction approach. So it's basically saying, what can we replace this very harmful behavior with for a less harmful behavior? And let's continue to try to dial it back. And while we're doing so, teach you adaptive, healthy ways to cope with the difficult feelings that you're feeling. Some of those skills that can be taught to help someone deal with the difficult feelings they're feeling are things like just emotion identification, learning how to communicate how I'm feeling, learning to think about the intensity of feeling. So often we say, I'm so tired, but we don't talk about how tired we are. Are we a 10 out of 10 tired? Are we a 7 out of 10 tired? Or are we a 3 out of 10 tired? All of those are still feeling tired, but the 9 out of 10 or the 10 out of 10 is much less easy to manage than the 3 out of 10. Often when we're seeing cutting, we're also seeing an individual who has difficulty differentiating between the intensity of those feelings. So it becomes all or nothing. I feel all sad or not sad at all, versus what I would recommend, which is more like, I'm feeling a 9 out of 10 sad today, but yesterday I was at a 6. To teach that nuance and teach that healthy coping as a way to integrate healthy interventions as opposed to the unhealthy one, which the child has chosen, which is cutting. Hope that makes sense.
Kevin, we have a hand raised.
Oh, cool.
Mm-hmm. Darren, did you want to speak, or did you want to?
Yeah, up to you, Darren. It's I'm fine either way.
I think they put it in the chat box.
Okay. Yeah. So this question is about how do you know when it's a real threat? How do you know when it's a real danger versus not? And I guess I'll read it verbatim. How do you tell the difference between a teen says that they're going to harm or kill themselves as a threat because they don't want to do something or face something and they want you to back off, versus they're really feeling that way and they're in danger? So I think that's a really important question, because it happens all the time. And I think that's the position that adults end up being in, we're trying to like evaluate whether it's whether this is real or not, right? The rule that I would share, that I share with all the families I work with, is saying I want to kill myself or I want to harm myself is never an okay way to cope. So those words themselves should be taken extremely seriously, not as a way of punishing for saying it, but as a way of educating. The reality is that if a kid in school says those terms in front of a teacher or staff member, anybody in school, it's going to set off a whole slew of policies where all of a sudden that kid's day is changed completely. Parents are called, therapy appointments are made. There is a series of actions that gets put into place. And I very much think that that's a similar pattern of action should be put in place at home if the child says the same thing, because that matches the reality of what they're going to experience in the world. Saying, for example, saying I want to kill myself is very different than saying, I hate this. We want to teach kids to say, I hate this versus I want to kill myself. So one way of, and I'm serious about this, one way to make sure that we're keeping our child safe is to if they say they're going to kill themselves or they're going to harm themselves, to put those plans into action. Meaning stopping everything that's happening, stop, sitting down and making a plan to go to the hospital. The child who didn't really mean it and is just trying to get you off their back will pretty quickly start to back that up and try to take it back, right? Try to explain to you all the reasons why they don't have to go. The child who is really suffering will probably also do that, but through this type of conversation, you start to get a lot more information than you did before. Now you're not arguing with your child. Now you're sitting down and you're really putting on the table how serious this is. And it's my recommendation that at that point, you're really figuring it out and you're going with your gut about how worried you are about what's truly happening. As another backup, I would suggest making a therapy appointment, right? If my son is saying I'm going to kill myself, I'm going to get them some help, right? And this is not a strategy to scare anybody off of mental health or to scare anybody at all. It's a strategy to get at how the child is really feeling and to cut through any noise that's happening, any fight about homework or project or girlfriend or boyfriend or whatever the fight was about. We want to cut straight through that and find out what's really going on. And 100%, if you need that support, I will call 911 and I will take you to the hospital right now. But if you don't, use a different word. Tell me you hate me. Tell me you hate this assignment. Tell me you hate whatever. But saying you're going to kill yourself is not an option unless you mean it. And if you mean it, we are going to find all the support we can for you to make sure you stay safe. Okay. Darren, is that helpful? Okay. And so that actually segues, I think, nicely into this next set of slides, because the next set of slides is really about, it's from my perspective as a psychologist of how we as professionals assess risk. And I want to present some of this as a way sort of to give a template for how to think about risk in the same way that we would in the office. So basically, the way that we assess risk is we come up with two lists. We come up with a list of risk factors, and we come up with a list of protective factors. And we look at the risk factors and the protective factors, and we try to assess which one is winning out. If there are a number of really intense risk factors, but not a ton of protective factors, we're getting increasingly worried about this individual. If there are a ton of protective factors, but there's one or two really intense risk factors, we can start coming up with a safety plan. and we can use some of those protective factors to mitigate the risk of the risk factors. So for example, risk factors, a recent or serious loss, a previously diagnosed mood disorder like depression, feelings of hopelessness, helplessness, guilt, and worthlessness, a previous suicide attempt, alcohol or substance use, disciplinary problems, other high risk behaviors. Sexual orientation confusion, I would leave in there, but I would actually broaden that a little bit to say identity questions. And when particularly we're talking about this group of individuals, middle school and high school, it's typifies the age range where this is a time of life when they're figuring out who they want to be as individuals separate from their family before they actually go on to try that out and live separately than their family. So identity is a really important thing at this time of life. Access to lethal means. So if there are guns lying around, or there are knives or pills or anything dangerous, that's a risk factor. Stigma associated with asking for help. So this kind of lends itself back to what I was saying about when a child says, flippantly, I'm going to kill myself. We want to walk the line, and we want to be very careful to say that we are here for you to help support you 100%. And at the same time, don't just say words just to say them. We want to destigmatize mental health and asking for help. At the same time, we want to take it seriously. Another piece that we don't always think about is cultural or religious beliefs. So if someone does believe that if they commit suicide, they might, for example, go to hell, right? That is a protective factor, because that's a factor that's going to make it less likely for them to make any risky choices. The two things that I look for in the office right away before anything else to assess risk are basically are the words that are being said. Are there any suicidal ideation and intent, number one? And number two, what is that individual's level of hopelessness? So the amount that they believe this has the potential to change in the future directly relates to their level of risk. So if they feel like it's never going to change, it's always going to be horrible and it's going to be this way, that increases that person's risk. If they feel like this is really, really bad, but I know it's going to get better soon and I can kind of picture it, but I'm really trying, that is a protective factor. We could read these, but I'll read them through. Protective factors: skills in problem solving, strong connections with family, friends, and community support, someone who feels connected, restricted access to those those lethal means of suicide, and cultural and religious beliefs. So the two that we are, the two at the top interpersonally that we manage are teaching problem solving, teaching conflict resolution, modeling nonviolent resolution of problems, and maintaining strong connection with our kids and with our families and community. Okay. Okay. Let's see, I'm just checking the time. So we have about 10 minutes left. I'm going to go through the rest of the slides in a couple of minutes, and then we'll open up to questions. So warning signs, related to the question, right? A warning sign does not mean that that person is definitely, if a kid, especially a high school kid, right, says, I'm going to kill myself, that doesn't necessarily mean they're going to do it or that they intend to, but it should be responded to almost as if they are, to model the severity of the situation, the seriousness of that word, and also to set the groundwork for the future to say, we will get you the support you need if you do need it. What we don't want to do is we don't want to dismiss those words of I'm going to kill myself. We don't want to dismiss those words as just, we don't want to assume it's nothing. We don't want to ignore it. We want to take it seriously, while at the same time know that it doesn't necessarily mean that there's a true intention there. Here's some more specific warning signs that can just be helpful with just observing your children. So if you notice them talking about dying more, talking about disappearing, jumping, other types of self-harm. If you notice a change in personality, like any qualitative change that really throws you for a loop, someone looks particularly sad or withdrawn or indecisive, trouble making decisions, right? Whereas this was someone who could make a lot of different decisions pretty quickly, and now they can't. That's a yellow flag. Any other significant changes in behaviors? One of the main symptoms of depression is changes in sleep, and that could be increases in sleep or decreases in sleep. So some people, when they feel low, they sleep more. Some people sleep less. Changes in eating habits and fear of losing control. Those are two others. So I hope that this information has been helpful. And I hope, even more importantly, I hope some of the information applies to your specific families. I'd like to just open it up to questions. We have about 10 minutes. I'm happy to talk about anything at all, whether it's on, was in the presentation or it's related in some way. Feel free.
Thank you, Kevin. I'm just going to stop the recording now. Thank you.
Okay.